This PowerPoint will discuss dementia, a chronic progressive form of impaired cognition. I'd like to start with just a brief overview of the different types of dementia, the different classifications. Just for interest, don't get too caught up in this. The book does, Lewis tends to go on and on, but that really isn't necessary. So Alzheimer's dementia is the most common type of dementia. The problem is there's a diminished amount of acetylcholine in the brain. And you'll remember from A&P that acetylcholine helps the transmitter get across the synapse. It is more common in women and in persons above the age of 65, which may be why it's more common in women as women live longer than men. There is a rare form of Alzheimer's that occurs earlier, and that is mostly genetic, and that can occur as early as the 30s and the 40s, but again, as I said, that's very rare. Alzheimer's cannot be diagnosed definitively until autopsy, and basically it's a diagnosis made of symptoms and client history. Vascular dementia is the second most popular type of dementia, and it usually has a cerebrovascular component. Well, it does have a cerebrovascular component. You may also have heard this called multi-infarct dementia. This is usually when a client has had a tendency to have a stroke, uncontrolled blood pressure. They may be a smoker. They may have had poorly controlled diabetes for many years. This type of dementia is more common in men, and that isn't too surprising, being that cardiovascular disease is still more common in men than women, although women are catching up. The secondary dementias, these are dementias that are caused by another primary disorder. Huntington's chorea is a very interesting disorder that is genetic and affects all of the men in a family. Wernicke-Korsakoff syndrome is related to alcohol intake. Other dementias that you will read about, dementia with Lewy bodies. It's similar to Alzheimer's in that it does have plaque deposits on the brain. It usually has a component of Parkinsonian type symptoms, as well as more hallucinating. And Pick's disease, very rapid form of dementia, very rapid progression. It's damage located in the frontal lobe of the brain where your filter is. So it affects your social graces. So again, don't get really caught up in all the specifics here. We want to be more focused on how we care for the client with dementia. What causes dementia? What are the risk factors? Well, we just don't really know. Sometimes we can look at things like I said on the last slide, uncontrolled hypertension or diabetes that can affect the blood flow to the brain, causing damage to the brain, may lend itself to a vascular dementia. Lots of research happening, looking at genetics, at cell damage, and so the best we can do is support that research and hope that we get more information in the future that can help our clients.
Diagnostics for clients with dementia will include screening tests such as lab work, possibly a brain scan like an MRI, to rule out pathology, to rule out some type of pathological reason for cognitive disorder. Standardized assessments can be used in screening clients to also identify a dementia. We've talked a little bit about the mini mental status exam. I have included that in the standardized assessment folder for you to look at. That is the full exam. Also, in the notes below, it'll refer to the page in Lewis where it gives a short example of it. It also shows you on that page another screening assessment called the mini cog and the clock drawing test, which we will talk a little bit about on the next slide. Also the geriatric depression scale, which I have included in that folder for you under learning materials and spoke about early on in the first voiceover. So these are important assessment tools for you. And then we can't discount the importance of both objective and subjective questioning, taking a really good client history. This is a time also where you may not be able to take a history of the client and you may need to rely on family members or caregivers. Clients who have cognitive deficits, particularly in dementia, often will have evidence of difficulty with math, logic, and reasoning. So let me give you a couple examples of that. My dad suffered from Lewy body dementia, and he had always been someone that was very good with math. He was always my personal tutor when I was trying to get through algebra. But my dad was a really smart man, and math was one of the things he did really well. So one night, they were out to dinner, he and his wife and another couple. And after dinner, when the bill came, my dad took the bill like he usually did, and he broke it all down and, to see what everybody owed and to figure out what the tip should be for the waitress. And he tipped the waitress incorrectly. He gave her quite a tip, a very large tip, so large that she came back to the table and gave the money back. So this made his wife think and look a little more carefully at what was going on, and in time she began to have to assume all responsibilities with the checkbook and paying the bill and those kinds of things. But that was a really early sign before they were even aware of a dementia diagnosis. Another thing that's very telling with clients with dementia is their lack of ability for abstract reasoning. So what I mean by that is if you said to a client with dementia, don't cry over spilled milk, or don't judge a book by its cover, they can't tell you what that means. They can't think about that and reason that and explain to you what that means. And so that is one of the questions on the MMSE. And you will see when providers interview a client that they suspect dementia, they will ask them one of those questions.
So here's the clock drawing test. The way that you administer it is simply you ask the client to draw a picture of a clock. So you can see on the upper left-hand side that that client has probably a pretty mild cognitive impairment. Or maybe is just a really bad artist, I don't know. But on the lower right-hand side, you can see that that client had a really difficult time drawing the face of a clock, and probably is very progressed in their dementia. So how does dementia manifest? Well, it's important to remember that it isn't just a memory impairment. It's a memory impairment that compromises social and/or occupational function. So we could say that I misplace my keys fairly often. I have issues with word retrieval and can't always pull the right word to put into a conversation, but it doesn't compromise my social and or occupational function. Just means I'm getting to be an old lady, having a senior moment. So that's really the difference. Certainly we just spoke about complex tasks, the inability to reason and think abstractly, and there's something called agnosia, and this is a dementia client looks at an object, maybe a key, and can't remember what it is, what it's for, or how to use it to open the lock on a door. Other manifestations that you find on this slide, difficulty speaking, choosing the right word, being irritable, poor hygiene, but remember, all in the vein of these are things that compromise social or occupational function. There is an interesting phenomenon that manifests with some clients with dementia called sundowning. So let's take a look at that on the next slide. So clients that exhibit sundowning seem to have, for some reason, a worsening of behaviors that occur late in the afternoon and in the early evening. So this is when we see an exacerbation of agitation, we see wandering, and even increased confusion. We don't know what causes it, and the best that we can do is try to work with the client to do things like plan active days so that they may sleep at night versus be up all night pacing and exhibiting behaviors. We should think about adapting the environment. So here's where we need, similar to the delirium client, we need that low stimulation, low lighting, calm environment. We need to certainly think about safety, and if the client's quality of life is impaired, meaning if they haven't slept in days, or they're a danger to themselves or others related to this sundowning behavior, then we need to think possibly about pharmacologic intervention. But again, we would do that as a very last resort. So in addition to the psychological assessment that we talked about as part of diagnostic criteria for the client with dementia, we're going to perform a history and a physical exam. The history is going to be very similar to the client that you suspected had delirium. You're going to ask all the same questions because you want to rule out a treatable cause. So you're going to ask about new medications, about trauma, about the client's usual status. You may need to bring the family members into this assessment if the client is not a good historian. Regarding physical assessment, we want to do a good functional assessment. What is their ability to perform activities of daily living? This is one of the most telling indicators of progression of dementia. And often when a client begins to lose the ability to perform activities of daily living is the time when a client may need to be placed in a skilled nursing facility. So it's good to have a good sense of where the client is with this. So I've given you a couple of nursing diagnoses here that I think apply to dementia. Notice that the first is chronic confusion as opposed to acute confusion in a delirium. In terms of outcomes, remember that in delirium we said we wanted the client to return to baseline functioning. In dementia it's a little bit different. We want to promote function and independence
and prevent decline for as long as possible. But we cannot expect the client to return to baseline. Additionally, we need to think very carefully about promoting safety. And we think about safety in the short term. Does the client need a sitter? Does the client need to be in a room close to the nurse's station? And we need to think about function for the long term too, and safety. Who is going to take care of this client at home if they're going home? Can we get them to a functional level that maybe isn't baseline but can be supported in the home setting? With nursing interventions, in keeping with the goal of promoting client function and independence, let's spend a little time on this slide. So we can support cognitive function in the early phase of dementia. It might just be by guidance. It might be by orientation with a clock or a calendar. But later on, the client may need supervision and may need decreased stimulation. We can promote physical safety both at home and in the institution. In the institution, location, location, location. So let's think critically about that. If the client has unsafe behaviors, is it possible to place them in a room near the nurse's station? We need to think about the lighting. We need good lighting. We want to avoid the use of restraints unless absolutely necessary. Smoking, driving in the community, very important things to consider. Wandering. So is the client at risk to elope, or if they're at home, are they at risk to wander away from home? This is something my dad began to do, and it became a problem, and so we had to eventually place him in a dementia care facility because his need for safety outweighed our desire to keep him at home in his environment. What can we do to enhance their sensory capabilities? Music is a great intervention. It can help to stimulate memory if you're playing old songs that they remember the words to, that, long-term memory stays intact for a while with dementia, so that's a great technique. Relaxation, massage is being used. Even that good old bedtime back rub is a nice touch. So we want to promote their ability to perform their own activities of daily living, but that means we've got to allow them some time. We've got to be patient with them, which isn't always easy to do in a busy healthcare environment. Structure is helpful to them. Simplifying big tasks in short, easy steps is a good thing to keep in mind. Thinking about behaviors, avoid triggers. So when I say that, I mean the little old lady who's 95, who's in a sundowning phase, and she's insisting that she take the bus home because her mother's waiting for her. It's probably not the best time to try to reorient her. This is a trigger. It's not a hill you want to die on. So it would be easier to validate what she's saying to you and try to maybe use a little distraction to get her off that idea about taking the bus home, and maybe see if you can get her involved in an activity or a meal or something. Again, relaxation and music are great techniques to soothe over behaviors. Regarding communication, in the early stages, we can, when it just seems to be forgetfulness that we're seeing, we can teach the client to make lists. We can give them written instructions, and they can pretty much work with that. But Later stages, when clients forget the meaning of words, we need to simplify our language. We need to eliminate distractions when we're communicating. We need to be patient, and we need to be unhurried. Familiarity is comforting, so as far as socialization, family visits, pictures, cards, items from home are good techniques. Simple structured activities are great. Pet therapy, one of the best. No expectations from a pet. They just come into the facility and they let the clients pet them. And there's so much to be gained from that experience. Care of plants. Sometimes I walk over from the school to St. Peter's and I walk through the assisted living facility, and I admire, they have quite a garden growing there that the clients who live there are in charge of taking care of. So, another good activity. It's important that we promote nutrition. Mealtimes are social occasions, so that's great. It's important, though, to think about, are they getting the nutrition they need? In later phases, clients tend to forget how to chew, forget how to swallow. They may be too agitated at the evening meal to eat. Some things that help are finger foods, high nutrition snacks that they can easily, take with them and easily consume. We might want to avoid naps during the daytime so that they'll sleep well at night. A nice sleep routine, that old-fashioned back rub, which is becoming a lost art in nursing. What other kinds of things can you put into a routine to get a client ready for the night and good sleep? Dementia clients are very comfortable inside of a structured routine. Most clients with dementia in the beginning are aware of their decline, so emotionally the best we can do to support them with a positive image and help them to create goals that are achievable, especially as they begin to lose function. And let's not forget support of the family member, the caregiver. It's very important.
So how do we communicate with the client with dementia? They may have memory loss, they may have some aphasia and just can't carry on a conversation, or they may demonstrate some behaviors. They may be agitated or aggressive. I'm going to, in class, show you a YouTube video that's quite entertaining and should lead us to some good discussion about how we communicate with the clients with dementia. Life stories are a very popular method of communicating and managing behaviors in dementia care facilities. So when my dad was admitted to his facility, they gave us a big packet of papers, and his wife and my sister and I filled in all the pieces, and there were questions about his childhood and his occupation and his hobbies and all kinds of things, and we provided some pictures, and then from that they put all of this together in a book that was the life story of my dad. And when he would become agitated or more confused at night, when he sundowned, a nurse's aide who didn't know my dad at all could sit with him and open this book and distract him a little bit and engage him in a conversation about his life from long-term memory, things that he could remember and speak to, where he went to school, or what kind of a fish was that he caught on this fishing trip, and who was that in the picture with him, and those kinds of things. Reminiscing is a very popular activity in dementia care. facilities, because many of these clients still have long-term memory intact, and it's very comforting for them to remember those things, just like having pictures in the room. Music therapy is a wonderful, engaging activity. When I worked in long-term care on the dementia unit, they had this activity called Big Band, and they would play music from the big band era, which for our clients, that was from their day, and they would give them all instruments and they could play along with it, and it was very fun and engaging, and helped to distract them sometimes from behaviors.
Most importantly, when interacting with clients who have dementia, this is some of the best advice from a really great lady.
Next, we're going to talk about the medications that are associated with this lecture. But before we do, I just want to give a little plug about studying for meds in terms of testing. So you want to know what classification the drug is and what its action is, because sometimes that can help you to think more about what the side effects might be or the nursing implications. So side effects, there's a ton of them, right? But you want to look at what's most important, what's underlined in red or written in red in your drug book. If there's some attention called to particular side effects in your text readings, or is there something individualized about your particular client? As far as nursing implications, this is why we look up drugs, right, before we give them. So is there something I need to know or do or check before I give the drug or after I give the drug? So starting with the cholinesterase inhibitors, the action, of course, we talked about it, they provide more acetylcholine, or they make more acetylcholine available to promote that transmission over the synapses. So side effects for these, they're fairly basic, but I would call your attention to dizziness, because immediately you should be thinking about safety. In terms of nursing implications, knowing that we have a client with dementia, very important that we have a baseline assessment and use a standard assessment to do that we can go back to and test yet again and compare and see where the client is at with their dementia. So this might be the mini mental status exam, it might be the clock drawing test, or any one that is your choice. You want to administer this drug in the evening. It tends to cause drowsiness, so that goes back to safety, dizziness. And, then is there a teaching component? Absolutely. You're going to want to make sure that when the client goes home on this medication, they certainly understand when to take it and how to be safe taking it.
So Namenda is a different classification of medication that also work to prevent and slow down the decline of memory loss for a period of time in the later stages of dementia. So the side effects look equally vague here, but I will draw your attention to anemia, so that a good nursing implication is that the client should have routine lab work done to evaluate for anemia. Also important, again, just as with the other medications, to have ongoing assessment of cognitive function using some type of standard testing, and again to consider safety regarding the possible side effect of dizziness. Adjunct pharmacology can be used if the client exhibits behavior problems. It would be a last choice option if their quality of life is interfered or they're a danger to themselves or others. Would be a good indicator as to whether or not these medications would be used. We certainly want to work collaboratively with other healthcare professionals in the management of a client with dementia. So physical therapy is incredibly important if they're still at that ambulatory stage, to help to make them safe and to promote that function for as long as we can, because once they can no longer ambulate, then they're at risk for all the complications of impaired mobility. OT are friends that can help us to have a safe environment with adaptive equipment. They can go out and assess a home and make recommendations to make it safe if a client is going home. Certainly, psychiatric staff, social workers are great support as far as ongoing testing and support of family members and caregivers. Nurses as teachers need to look at two more nursing diagnoses: caregiver role strain and interrupted family process. We need to anticipate the stress of the caregiver. Very often they don't understand the disease process. They may tend to personalize it. I'll give you the example of my father and his wife. She was so distraught and upset by his loss of cognitive function. They'd become confused and not know who she was. He would ask her what she had done with his wife, and he would be angry, and she would personalize this. She became impatient with him often, and I would be down visiting, and she would kind of snap at him, and so it took a great deal of support and teaching on my part with her that, this is normal and he can't help this and he doesn't mean this, and, but here's what you could do instead, Why don't you try to distract him? Why don't you talk with him about that trip you took with the camper when you were first married to the Cape, and things like that helped her to develop coping strategies. Interrupted family process is a great example that I can give you also with my dad. He really took care of, they live in a farmhouse on 20 acres of land. He took care of all of the yard work, the mowing. He split all the wood for the furnace for the winter. And he became unable to do these things because it became a safety issue as well as a functional issue. She began to take on all of these extra tasks, and that added to her strain. She had to take on, as we talked earlier, the financial pieces. She had to manage the checkbook. She had to manage the money. So his interrupted role in the family caused her even more strain. So just because sometimes it's nice to put a face with a name, and for you visual learners, there's a picture of my dad and his wife, and this is their dog Wags that they rescued. This was shortly before my dad had to be placed into a dementia care facility. And this picture actually speaks to interrupted family process as well, because my father's wife initiated this adoption of Wags because she knew my dad could no longer protect her and probably would have to be placed somewhere, and she would be living alone out in the country, and wanted the protection of a dog. So there he is, Dr. Tom and his pal Wags. Let's think about the outcomes we want for our caregivers. We want them to be able to understand that disease process, because understanding it will help them with acceptance and coping. We want to watch for positive interactions during care, because if we see negative interactions, we need to intervene. We need to really closely monitor for abuse, because stressed caregivers can be abusive. Therefore, there needs to be resources available for the caregiver. They need to know who they can call to help, and they need to have a backup plan. So another example with my dad is that my sister and I routinely provided respite to his wife. We have other siblings that live out of state, and so, for example, when my brother and his wife had their last baby, we sent her down to visit, and my sister and I took turns staying with my dad. My dad's wife had to have cabbage done while she was hospitalized. I was the backup plan. So even though it happened quite quickly, we had a plan in place that I would be the one that would be able to come down and stay with him. So good planning can help the caregiver, can prevent abuse, can assist in coping. And last but not least, how will we evaluate the care of our client with dementia? Well, we're going to look at what our outcomes were. Are they safe? Were we able to maintain their function for a time? Do they have good quality of life? Have their physical needs been met? Remember, physiologic needs on Maslow's hierarchy are very important. And is the caregiver doing okay? Those are all the outcomes that tell us that we've done a great job with our care of the client with dementia.